Good morning, everyone, and welcome to our virtual conversation on World Diabetes Day. We're thrilled to be with you all. I'm Susan Papp, the Director of Policy and Advocacy at Women Deliver. For those of you who may not know Women Deliver, we are a fierce advocate for the health, rights, and well-being of girls and women around the world. We focus on the health, rights, and well-being of girls and women by catalyzing action, building capacity, sharing solutions, forging partnerships, and creating coalitions that spark action, political commitment, and investment in girls and women. And today, on World Diabetes Day, we're bringing the topic of diabetes and pregnancy to the fore. It's a very under-examined topic, and we here at Women Deliver feel it's important to be discussing it today. As some of you may know, the theme of this year's World Diabetes Day is Eyes on Diabetes, and it centers on screening for type 2 diabetes and diabetes complications. But without a specific emphasis on screening for diabetes in pregnancy, we feel that efforts will be woefully inadequate. And that's why we're here today talking to you about gestational diabetes. Over the course of the conversation, you'll hear me refer to gestational diabetes as GDM. It is the onset of diabetes during pregnancy, and it's a serious yet untreated condition that affects 14% of women worldwide and 18 million births per year. That's 1 in 7 births per year, or 1 in 7 are affected by gestational diabetes. Pregnant women in low and middle income countries are not consistently screened for GDM, even though these regions account for 85% of global deliveries and 88% of GDM cases. Women with unmanaged gestational diabetes run higher risks of complications during pregnancy. These complications can include increased hypertension, obstructed labor, postpartum hemorrhage, infections, stillbirths, premature delivery, and newborn deaths. Well, in addition to these short-term complications of gestational diabetes, the long-term implications of gestational diabetes are also very, very alarming. They can contribute to the rising burden of non-communicable diseases. More than half of all women with gestational diabetes will go on to develop type 2 diabetes within 5 years of delivery. And these women can then go on to have greater risk of other NCDs like future obesity, hypertension, and cardiovascular disorders. The damage goes beyond the woman, and her child is 8 times more likely to develop type 2 diabetes if their mother has untreated gestational diabetes. While this evidence begs for intervention, gestational diabetes remains an overlooked topic, particularly in the maternal, newborn, and child health space. What we must all recognize is that pregnancy provides a critical window for us to establish services, improve health, and prevent the intergenerational transmission of NCDs. There is promise on the horizon. With the launch of the new FIGO guidelines on gestational diabetes and the Colombo Declaration for Action, this issue is getting the attention and the momentum that it deserves. And today we hope to continue to build that momentum, and it's time we all feel to bring the maternal and child health community fully on board onto this topic. Today we'll have a discussion with 2 esteemed panelists on the critical need to integrate gestational diabetes into the maternal, newborn, and child health continuum. I'm delighted to be joined by Dr. Hema Divakar. She's a consultant obstetrician and medical doctor joining us from India, and she's also a member of FOGSI and an ambassador at FIGO. I'm also joined by Chandrika Wijeyaratne, a professor in reproductive medicine and endocrinology at the University of Colombo in Sri Lanka. Now let's turn to the panelists who can tell us briefly about themselves and the important work that they do. Hema was having some technical difficulties, so she'll be joining us over the phone, and now I'll turn it over to Hema for the first question. Hema, could you please introduce yourself first, please?
Yeah, I'm Dr. Hema Divakar from Bangalore, India. I happen to be the co-chair of the Diabetes and Pregnancy Working Group at the FIGO, which is an international body of the OBGYNs.
Thank you so much. And Chandrika, could you please introduce yourself? an important issue to the reproductive, maternal, and child health community. And can you also tell me if you think it's getting enough attention?
Yes, the diabetes in pregnancy essentially is a silent disease. So can you imagine that when a woman in pregnancy walks into our consulting room and she has no clue as to what her sugar levels can be, and we in India find 1 out of every 5 such pregnant women who are otherwise normal with very high blood sugars, and that's an alarming number. So just the scale of the problem itself is so overwhelming that it really occupies the center stage as far as diabetes in pregnancy with respect to the millions of deliveries that happen in our own country. So we have about 3 to 5 million diabetics in pregnancy every single year, the new cases. So the scale is so overwhelming that it really is a significant and important issue, because if we don't detect this, there are both problems for the mother and the baby in the short term and also in the long term. Not only that, as OBGYNs, we may find and encounter some difficulties during the delivery process, but more importantly, in the long term, this young mother may turn type 2 diabetes in about 2 to 5 years after delivery, and her baby is prone to childhood obesity and early onset type 2 diabetes, which means that this not only affects this generation, but also affects the health of the generation next. So indeed, it is a very significant problem, and I don't think the importance given to this issue of diabetes in pregnancy in the perspective that I have just mentioned, it still deserves a lot more attention. It's just not a complication of pregnancy and it's over, the delivery process is done, and then you forget about the whole thing. No, it has very, very long-lasting complications in terms of the quality of health, both for the mother and her offspring.
Thank you so much for providing such a comprehensive overview. The numbers are staggering. The intergenerational effect of gestational diabetes is something that many in the community don't recognize, and it's important that we bring that to the fore. Could you now tell me why FIGO decided to take on this issue, and can you tell me a little bit about the new guidelines that were rolled out last year?
So FIGO is a parent body, international parent body with more than 138 countries, all the specialist OBGYNs, those of us who deal with women's health care. And when the patient is pregnant, of course she will see us first. So it is really, really crucial that we are the first point of contact for this pregnant woman whose sugars are tested and found to be high. So we label her as diabetes in pregnancy, and further on, it's entirely a matter of her right and our responsibility to sail her through a healthy pregnancy and an outcome, and also keep in mind the long-term issues that I have just said. So it was, really, really important that FIGO pays attention to make this the center stage, because the issue unfolds in the period of pregnancy, which is the forte of the obstetricians the world over, and the new guidelines. Because there's a huge controversy about who should be tested. Do we select the pregnant women who are at risk? Well, the FIGO has now agreed upon that universal testing, that is, every single pregnant woman is to be perceived at risk for hyperglycemia or high blood sugars, and we should offer them the testing, because in case it is missed out, again I emphasize short-term, long-term, we will be missing out a lot of problems with her. So universal testing is one thing that has come out of FIGO guidelines, and also FIGO, being the parent body, has paid utmost attention to the practical and the pragmatic problems in the affluent, in the middle income and the low income countries. So when we presented our data to FIGO, which is evidence-based and published, and so they have now agreed upon the different kind of testing which are feasible in different geographies, which are equally acceptable, and also FIGO has said you pay attention even before and beyond pregnancy. So the pre-conceptual care and the post-delivery care long term. It's not just 6 weeks where she needs to be tested again, but also year after year after year to make sure that some preventive measures are adopted. So all in all, the FIGO guidelines have got to focus a lot more responsibility that we as gynecologists world over owe to the women in the world.
Thank you so much. You talked about the guidelines and the need for universal screening and testing and the evidence base that came out in the papers last year. But I'm wondering if you could help those listening in today have a more practical example of what's happening on the ground. So could you tell me what's happening right now in India?
It was about 5 years ago when we recognized that the cases of high blood sugar are not far and few in between. And you test them and then it comes to light. So those clinicians who were not offering any tests, it was like a blindfold. It was like ignorance is bliss. They don't even know that the women had high blood sugar and she needed special attention both in the short and long term, and that was how it was. But once everybody started testing, more and more cases came to light and more attention, and as I said, the surveillance and responsibility we started increasing, but the capacity building of all the OBGYNs in our own country, getting the professional bodies to agree upon some uniformity in the offer of testing and management, getting our government to release the recommendations, and the most challenging of all, getting it off the ground, the implementation. So the gap between the idea of universal testing in the most simple and practical way that we have now laid down for our country and also endorsed by FIGO, the gap between that and actually how many of our women are receiving the test, that gap needs to be bridged in a much stronger and an objective way. And so we're on a massive attempt to build the capacity of the healthcare providers so that they will offer the testing. And the question of what next if the test turns out to be positive is also a mind-boggling issue because there needs to be repeated visits and long-term care on one hand. On the other hand, the advocacy issues have to be strong, and I'm very happy to be participating in this panel today to sensitize just about everybody who's online listening to us that it is a issue which deserves much more focus than ever before. And if every woman demands that she needs to be tested for her sugars in the interest of her and her baby, and every clinician supplies the test and the care thereafter, I think it will be a dream fulfilled. So as far as the ground realities in India, as I said, it's a huge country, the 30 million deliveries every year, and to the government's mandate and the FOXI, that is Professional Organization Mandate and endorsement by FIGO, is that women should be tested at least twice during her pregnancy, which means you can just imagine 60 million blood tests need to be offered, and I think we are really far away from the ideal mark. Those who have the access to healthcare are getting tested when the providers are aware. Those women who are aware are asking for the test, and okay, some of them fall into the bracket of testing them. But in huge public health systems where the time is a constraint, the instructions to the patient, the drawing of the sample, the interpretation of the test results, well, we have to still build the capacity and strengthen this continuum of care as how we would dream of. So we are not yet there, Susan.
Thank you for that. I'm going to come back to you and ask you a couple of follow-up questions on some of the things you said. But now I'd like to introduce everyone joining in to Dr. Chandrika. Dr. Chandrika, could you take some time to introduce yourself, and then we'll dive into your first question.
Of diabetes emphasize that gestational diabetes and high blood pressure during pregnancy are markers of what is in store for the future of this woman and her family. Issues like family planning, since the interpregnancy period, as Dr. Hema was referring to, is extremely important. In most of our societies, the great changes of the hormones of during pregnancy are the main reason for pregnancy, diabetes. Therefore, if a woman enters without realizing that she's frankly diabetic. That is an unacceptable situation. Words, as well as we would emphasize on a healthy lifestyle approach beyond the birth of her baby. Feeding with optimal food and drink would be extremely important to advise this mother, and therefore a holistic approach to the problem is recommended at all times. As we know, diabetes and high blood pressure do not have any, so we need themselves at least once a year after the birth of her baby, where gestational diabetes was discovered. This is not to frighten.
Okay.
As we know, diabetes and high blood pressure do not have any symptoms.
That's okay, you can go back.
We can have as healthy a pregnancy outcome like a woman without diabetes. I find this to be clearly like boarding an aeroplane, where we would not board an aeroplane without getting the engineers to check its functions for any kind of malfunction. And it is just like that. And if we explain to the women,
Let's wait.
Thank you so much, Chandrika, for that really insightful overview of your take on the situation. Can you describe for us what diabetes and pregnancy is like for women affected in Sri Lanka, and what some of the services and provisions are available for her?
and the inequalities of education, income, nutrition, and healthcare, where the women may not be very familiar with what has to be done in terms of the things that you need to have a day-to-day intervention. Me from the macro level to go to the micro to share with you a typical case study which I encounter on a day-to-day basis, whom I often refer to as Mrs. Sri Lanka. She is a 41-year-old mother of 3 children and is expecting her 4th child quite unexpectedly due to an unplanned situation with no family planning. She has very poor social supports. She comes from a very poor social background, and her husband is often in prison due to petty thieving. And her diabetes is detected because the field midwife encourages her to come for blood sugar testing within the first 2 months of her pregnancy. And once this is discovered, we give her the appropriate diet as well as insulin, which is provided free of charge from the state hospital. However, Mrs. Sri Lanka has to come in for regular blood meter. Now, what happens is that we as healthcare givers find a paradox. Mrs. Sri Lanka's blood sugars tend to be very low and she runs into hypoglycemia at home, while in hospital, when she's on the hospital diet, they tend to be very high. And when we looked into this, we found that Mrs. Sri Lanka has very little food at home. She's the last person to eat once she has fed her entire family. And this is much the case in most parts of the world. And therefore, we as a care team can solve the issues at that moment of providing her through the hospital monk and the social service department additional food and rations. But as well as she has a healthy baby at the end of these interventions, as well as she has sterilization by choice. Nevertheless, what is her future and what of her children? Can she actually continue with her day-to-day assessments of blood glucose and her blood pressures and taking her medications? It often does not happen. And very often the children would develop the same problems even earlier than what Mrs. Sri Lanka did. So it is a vicious cycle of diabetes begets diabetes, and it is entirely through the fact that this is a high-risk family, and the high-risk mother developed the problems of gestational diabetes during pregnancy, and now she is gone into a permanent state of diabetes from her 40s. Her daughters and sons are likely to develop this even at an earlier age, and very often the problem is the unhealthy food and dietary habits due to their poverty and lack of knowledge. Therefore, my humble plea is to prevent all these women and their children from being subjected to this vicious cycle through a proper screening procedure as well as a holistic approach to health care in terms of health education and promoting good health through lifestyle changes.
Thank you, Chandrika. That was a really telling example of Miss Sri Lanka and the realities that she faces and some of the challenges that she encounters as trying to not only be screened for diabetes and pregnancy and hyperglycemia, but also how to treat it. There are many, many barriers in her way. Taking it back up to the macro level from the micro level, I want to revisit something that Hema and I were speaking about earlier, and that was the questions of the rollout of the guidelines, the FIGO guidelines. The description of the situation in Sri Lanka was very telling because you were able to see some of the challenges that women confront in their daily realities. But in addition to those challenges that women confront in their daily realities, you have a variety of systemic issues at play. And let's take another trip back to India and talk a little bit about some of those systemic challenges as you're trying to roll out the FIGO guidelines in India. So over to you, Hema. Thank you.
Yeah, thanks, Susan. See, even ahead of the FIGO guidelines being rolled out in the year 2013, we recognized that in India, if there needs to be a multi-speciality team to take care of a woman who is diagnosed with diabetes in pregnancy, that would be really a huge challenge and a clear no-no, because she sees maybe a medical officer or a frontline healthcare provider or at the most a specialist OBGYN, and that's all the human resource that is available to this woman. Whereas when she is diagnosed to have diabetes in pregnancy, as a multi-speciality, the ideal scenario is she'll need the help of a dietitian, she'll need the help of an education counselor, she'll need the lifestyle expert as in the pregnancy exercises and how she should be controlling her weight and the surveillance at repeated visits. She will, of course, need a diabetologist's help in the event that her sugars are not under control and she needs to be put on drugs and insulin. But given the numbers in India, we recognize that for every such woman, we cannot source this multi-speciality team, and it has to be the OBGYN who has to multitask. She has to double up as her primary care provider, both in terms of her pregnancy and the related issues of high blood sugar, as in how to monitor, what to eat, what not to eat, how much to exercise, and everything that the multi-speciality team should do, we have to offer it as a one-stop diabetes and pregnancy clinics. That is, that's the only practical, feasible thing. So, which meant that we had to train the OBGYNs in a special certification course, which included all these components, so that when they do the testing and when they diagnose these cases, they will be themselves empowered to take her through the next couple of tests, and out of every 100 women, there may be a bunch of 5 who will actually need the diabetologist or the specialist care. Again, I'm coming back to the numbers. If we have 3 to 5 million pregnancy with diabetes, we have only 30,000 gynecologists in the country, and we have only 1,000 diabetologists in the entire country. So even if we do want to refer them to a specialist for the care of her high blood sugar, it's not going to happen. So we have to take the responsibility, as I said, to do the best for her. So we instituted the training courses so that the OBGYN becomes the one-point contact. And our 30,000 gynecologists, as in today, about 3,000, 3,500 gynecologists are being trained. By the time the FIGO guidelines came in at the Vancouver FIGO conference, India was one of the countries where both the professional bodies and the government had rolled out the recommended guidelines, which are in alignment with the FIGO guidelines. So we now have the cascade of the international body as in FIGO, the national professional body as in FOXI, and the government of India. All the three are in alignment of what we should be doing with our pregnant women with respect to hyperglycemia and diabetes in pregnancy. So all this is seemingly uniform, but as again I said, the care that we should reach to every single woman in metros, yes, we can say, and that something better than nothing is happening, and the entire group of clinicians and healthcare providers are sensitized, but they are still staggering with the actual off-the-ground implementation. As you said, the system problems. Where does she go for the testing? How does she take the 75-gram glucose as in the challenge test? Who interprets this? If she is positive, where is the referral system of linkage? It is to be integrated into her routine antenatal care. But when she is diagnosed to have diabetes in pregnancy, she needs to be seen by the same team of healthcare providers time and again. Her number of visits will be more frequent, which again is a system overload. Her short-term and long-term problems are going to be there, needs to be paid attention to, and she may have to be referred to a higher center for delivery. So those linkages and networking have to be pretty much more strong, and something to motivate her to keep to her lifestyle and diet and monitor her sugar. It becomes a very intensive exercise, both for the provider and the woman who is diagnosed with diabetes in pregnancy. So therein lies the challenge, because it's not a one-time visit and a one-off care. So the FIGO guidelines have strengthened our perspective that we need to be really serious in implementing this, and I think we are slowly and steadily inching on the right track. Long way to go, but
yes, a very long way to go.
we know the roadmap.
You had talked about the OBGYN needing to wear many hats in the provision of care for their patients. And just sort of a question from a devil's advocate point of view, do OBGYNs, recognizing the burdens already placed on them and the fact that, yes, while there are many more OBGYNs than diabetologists across India, is the capacity really there for them to take on this challenge in a meaningful way? Or is it also important for us to bring in other cadres of care like auxiliary nurse midwives and others who can really help provide support to the growing need?
When we started this whole exercise, Susan, we thought we would sensitize and build the capacity of OBGYNs, but we soon recognized that that's not enough, and now we moved to the next level of building the teams, as in a nurse practitioner, a counselor. There's a whole project of Skill India where there are young girls who double up as youth ambassadors for preventive care and promoting well-being and health. So if they're just good communicators and we can train them, they need to talk to these women time and again. So that's the new cadre that we are building in. The nurse practitioners, of course, are part of the team. The junior doctors, the internists, and the medical officers, the general practitioners, and of course the OBGYN. So now we have expanded our thinking to the fact that there needs to be larger number of healthcare providers of different cadres who will need to take care of this women. But if it comes to handling the complications, then of course it has to be the specialist OBGYN and the diabetologist. But the vision is to minimize the complications by prevention, early detection, timely advice, rigorous monitoring, and getting them to just maintain with the diet and lifestyle so that lesser numbers will be required to be taken care of the real specialists. So that is the expanded team of healthcare providers that we are looking into, which again means about 1 million.
Wow.
Yes, we
That's
need
a
to
lot.
be trained to take care of the 5 million. So that's the scale. So the scale is very big, but at least we have now recognized on a bigger canvas that this is what we need to do.
Okay. Unpacking that a little further and traveling back to Sri Lanka, I'd like to hear a little bit from Chandrika about some of the successes that you've had in treating women who present with diabetes and pregnancy, and whether the team-based approaches to care have been successful, and what other learnings you would like to share with the audience.
Well, in Sri Lanka, we are in a fortunate position because women have a great potential to be social and health leaders for the simple reason that there is a very high literacy rate as well as a very robust healthcare system at primary care level for mothers and children, which have been running very well over the past 5 decades or more. So the reason I would say that gestational diabetes and its approach as a universal screening as per the FIGO guidelines system was very easy. Our policymakers and planners were very receptive when we went and showed our own diabetes was becoming during pregnancy. And we had many training program from central now encourage every woman to be screened with a blood glucose measurement rather than the previously conducted. The midwives are able to supplement what the tertiary care or the higher level care hospitals would give in forms of advice and treatment to the women during their pregnancy. And we've also tried to roll out as much as possible and where the women are reminded that they need to control their weight gain, that at grassroots level, how common gestational diabetes has got worse in the past 10 years. Earlier, at the turn of the millennium, it was 1 in 10 women being affected with GDM, but now it is as much as 1 in 7 or even 1 in 6 women in urban areas. Information to the schoolgirl. So we are particularly worried about the next generation, and we try to inculcate a better healthy lifestyle commitment in terms of diet and physical activity and avoiding heavy starch-based meals, which is a common factor particularly in our lower socioeconomic groups. Additionally, we have encouraged family planning so that there is a planned pregnancy in subsequent pregnancies. We know that women throughout the world and therefore not their eye affection and even foot loss. Women are not spared from these simply because being women. In fact, they do worse than men. And therefore, we try to warn them that detecting their diabetes during pregnancy or the diabetes risk and trying to prevent them going into these complications has to be dealt with again through the maternal and child health program. Since they do come regularly to those clinics at field level for immunization and new proper advice from the field staff, which includes doctors, community nurses, and the community midwives.
Chandrika. One of the things that you said that was so striking to me was the rise in the prevalence of gestational diabetes and the fact that we need to be paying attention to these signs, thinking about the lifestyle and life cycle approach to treatment and prevention. I'm curious to hear from Dr. Hema about some of the long-term implications of untreated gestational diabetes. And, as you're talking to health system planners and practitioners across the region, we understand an enormous cost would go into treating these women and screening them. But I think when you look at the long-term and short-term health implications, it really helps make the case for why it's so necessary. But it would be helpful for you to explain to the audience here listening in some of the long-term implications that you've seen come out of untreated gestational diabetes. Over to you, Hema.
So there are the two clear streams. One is the long-term implication for the mother, and the second is the long-term implication for her offspring. About the mother, there are many now in our own country who are just aged about 32 or 35 years, and they're already diagnosed with type 2 diabetes. And they say, hey, and look back into their history, then these are the very women who had the gestational diabetes, but nobody told them that they have to come for an annual check and they have to contain their weight, they have to be paying attention to their diet, and this is what the lifestyle will influence the long-term problems, etc. So there are many, many young women, to be precise, about 30 to 35 million women in our own country who are women with type 2 diabetes, and half of them have had gestational diabetes, either detected or detected late or undetected, but they are in the same bracket. So that again, in terms of numbers, is a mind-boggling numbers. And what happens to these women who unfold their type 2 diabetes much earlier on in their life than expected? At 32, 35, within 40 years, they have been recognized to have type 2 diabetes, and there are issues of metabolic syndrome, the cardiovascular accidents, the non-smoking Indian community. There are many admissions of women with cardiovascular accidents in our inpatient departments, which was seen the numbers like never before. So this is really a long-term implication of the quality of health and mortality issues for reasons beyond the mortalities which occur during the delivery times, which is often referred to as maternal mortality, and the attention is paid to save the women when she delivers, but very soon she becomes a type 2 diabetes, she gets into metabolic syndrome, she gets into other long-term complications with cardiovascular accidents, she has a poor quality of life, and finally she has to meet her end. So that's the whole track that we have to pay attention to, and as of now, the policy for healthcare of a woman who is post-delivery. Beyond the contraception, not much has been thought about, at least by the government and the public sector. It is only in this era that the numbers of menopausal women are really on the rise, and we need a policy in place to pay attention to their long-term healthcare in terms of the repeated annual visits and preventive care. So that's about the mother. Whereas for the baby, we always mark, as Chandrika said on the immunization card, we have to mark that this baby is born out of a mother who had diabetes in pregnancy, so that the specialist who takes care of the child, or whoever is the healthcare provider for the child, has to pay attention to the childhood diabetes, obesity, because these, by the age of 10 to 12 years, they're obese, if they are girl children, they're polycystic, and they have their impaired glucose tolerance earlier on. Like by the time they're 20, 22, their glucose levels go in the abnormal range, and they unfold into early adulthood diabetes. So if you see a large diabetic population floating in India today, heading towards being called the diabetic capital of the world, you will recognize that half of these were due to the attention that we had not paid 2 decades ago to millions of women who delivered, and probably the gestational diabetes was missed. So many babies which came out of these diabetes in pregnancy offspring which had childhood obesity, because that again is emerging as a big problem in the country, and many young adults diabetics. So the productivity, the quality of life, the morbidity, the long term. So there is a lot which is unseen, and these connections need to be established in the minds of the clinicians and the people who are seeking care, so that they have to pay attention to their past, present, and of course the future.
Past, present, and future. So breaking the cycle by thinking about antenatal care, intrapartum care, and postnatal care, follow-up and review, in order to really stem this growing tsunami of NCDs that's coming up, particularly in places like India.
Yes.
Looking forward, where we go from here, I'd be curious to hear from Chandrika about where you'd like to see the community, who's really at the front lines of tackling diabetes and pregnancy. What do you hope to have achieved in 3 years' time?
That is the maternal and compartmentalized and running parallel. We need to have a unified approach, and I'm really hoping that in many parts of the world where gestational diabetes is indeed a problem, wherever there is a high risk of diabetes, we have high gestational diabetes, and it must be a unified 3 years. We expect such an approach to really be rolled out through well-trained and well-oriented healthcare workers at grassroots level. It should not be confined to families, but to encourage them towards prevention and health promotion. We need to achieve screening every pregnant woman with a blood glucose testing, and to also monitor and evaluate such programs. We need to collect our data, map out the geographic areas where it is higher, to encourage the non-health sector to help us in trying to bring about a healthy change in the lifestyles. Mothers and women's groups must become adequately empowered to address the problem of the prevention, and know our environment starts in the mother's womb. It is indeed a womb to tomb quest, but we need to make sure that our babies have a healthy environment in the mother's womb. And this can easily be achieved by simple screening and a commitment to a holistic care. A life course approach, therefore, is something that every country, community, and society must address, because we need to actually hand over the responsibilities that we would have healthy community and basically happier people. In terms of maternal and child health, therefore, it cannot be just the obstetric component but needs to take a more wider approach into looking for diabetes and high blood pressure, and that is my plea to the entire world. Thank you.
Thank you, Chandrika. The womb to tomb is a very powerful image that you painted for everyone here listening in today, and we agree that the lifestyle approach is a strong approach to take, and one that's very necessary. Before we break, I wanted to hear from Hema about what she sees as the future in India and where action is really needed in India moving forward, and what you hope to do to be able to address the highest unmet need around the issue in India, but also globally. So over to you, Hema.
Yeah, Susan. brainstorming within the working group of FIGO, which is meant for the issues around the hyperglycemia in pregnancy, the HIP or diabetes in pregnancy, we've come out with a three-pronged strategy. One is for advocacy, the second is for capacity building, and third for research. And we hope that the plan and the outline laid on all the three prongs would be instituted, first of all, in this large and a challenging country called India. And we hope that this would then have us learn the lessons to set the way forward as a role model for the entire South Asia and also the African countries. Because if we can work despite the diversity and challenges in India and set something right, then the other countries which I mentioned, we can move ahead very swiftly and smoothly. That's what we are hoping for. So all the three prongs, advocacy, capacity building, and more research to have more insights into what would be the best way forward. So it's a learning all the time, and I think we have put the best foot forward. And this is what the vision is, to turn it into reality, starting from India, then to South and to Africa for sure, all of us dealing with similar issues. So that is the action plan.
Thank you. That's really helpful. Advocacy, capacity building, and the need for more research. Research in particular, I know, is of interest to many in the maternal health community as they're trying to wade through this new issue and looking for evidence about modalities and treatment and case examples. So everyone listening in today, I think that's one of my biggest take-home messages for everyone, is more investment in research and the appropriate steps to move forward. And using the FIGO guidelines as a launch pad for that. Before we break, I'd like to ask Dr. Chandrika for her final thoughts. If there was anything she wanted to provide to those listening in today, any final considerations or words of wisdom.
Well, I really must congratulate Women Deliver for taking on this tough task of addressing the problems of gestational diabetes throughout the world. It is the impoverished societies that are facing and tackling this problem and are basically unable to cope. And I'm extremely grateful to you for initiating this dialogue, since we need the support of not just the health sector, but need the wider sectors of non-health, particularly in the field of education, as well as the other communities that deal with sectors such as food and drink. And as you know, women have to face so many issues. They have many stresses in life, and their coping skills, however, are pretty good. And we need to encourage the women to have healthy pregnancies by starting early. So I would recommend we go
Thank you, Chandrika, and we appreciate the fact to be able to work with you to elevate this much needed issue. Before we finalize the call, I would like to offer Dr. Hema the chance to have her final words of wisdom for those listening in.
Well, while thanking the Women Deliver who have offered us a brilliant platform to exchange some of our concerns and the roadmaps for further action, I would like to say that if any one of us has not done enough for diabetes in pregnancy before, the second best time is now. So we need to talk less and get into the action mode, and that will be my final message, because there's a lot to do.
Great. Talk less and get into action. So for those of you who are interested in learning more about gestational diabetes and some of the related causes and implications, I'd invite you to visit womendeliver.org. We have a special spotlight page up today on World Diabetes with a host of resources for the community to peruse, and we will be continuing this conversation later next year. We hope to start a webinar series around diabetes and pregnancy and some of the challenges and opportunities both for the NCD community and also the maternal health community. So I look forward to seeing many of you later next year, and thank you so much for tuning in today.